Hi everyone, I'm Sophie and welcome to the video. Today I'm going to be comparing my old job in the hospital to my newer job in a nursing home. I do just want to explain why I haven't posted this video already, because I said I would post it like 4 weeks ago and I haven't. I've just moved into a flat with my boyfriend, if you could not tell by the new surroundings. So that has been quite stressful and I haven't wanted to make a video. And also, I haven't been in my new job for that long. I mean, I have now, but before the past few weeks, I hadn't been in very regularly, and I'd only really been working there since May or June, one of them. So I really have only been there a couple of months, and I didn't have regular shifts, whereas now I do. So I've got more of an understanding of my job role. I feel a bit more comfortable there and a bit more confident, so I thought it was probably best to wait until about now until I made a video about it. The way I'm going to structure this video is literally just comparing one aspect of the hospital job to the same aspect in the nursing home job. The first thing I want to talk about is the way the team is split. So in a hospital, on the ward I was on, we would have one nurse in charge, 2 nurses, 1 band 4 and 4 HCAs. So that would have the ward split in, so you have 4 bays and 4 side rooms. They'd split the team into Team A and Team B. Team A would consist of 1 nurse, 1 band 4 and 2 HCAs, and that would be for 2 bays and 4 side rooms. And then Team B would be 1 nurse and 2 HCAs. In the nursing home, it is a bit different. You only have 2 nurses per floor. There are 3 floors in the nursing home I work in. Downstairs in assisted living, you have 2 nurses, 1 per floor, and about 8, no more than 8 carers. Sometimes there's 6, sometimes there's 7, sometimes there's even less. It really does depend. And it's the same sort of rotating upstairs. You have 1 nurse and then 8 carers. Now, like in any care setting, when you come into a shift, you will have a handover. Now, coming onto a day shift in the hospital, after your handover, you will go and start your medication round. And I would usually have between 8 and 12 patients to give medication to. And honestly, that can take up to 2 hours. You don't have a lot of patients to go to, but in the middle of doing all your tablets, you could be getting phone calls from doctors, or doctor wants to see you, or someone else is phoning, or someone wants you to come and look at someone's bottom because it is red, or you know, a new wound, something like that. In the home, you have no more than 30 residents, so you do have quite a lot more, but they don't always have a lot of medication, and it's the same medications you're giving every day. So of course you have to check the MAR charts, check the drug charts, but you're giving the same one every day at the same time, so you kind of get used to who has what and all that. So it does flow a bit better. We'll say there are less, not distractions isn't the right word, but you know, I was saying in a hospital you get called here, there and everywhere. In the home, when you get doing your medication, you don't tend to get pulled away to go and do something unless someone's had a fall or someone's having a seizure, or you know, something like that. With personal care in the hospital, you are expected to go and help when you can. Yes, some nurses don't go and help, I guess out of personal choice, but you know, it's a team thing. You should help if you have the time. I understand in the hospital it is, you know, you don't have a lot of time, but likewise in the home you don't always have a lot of time. I very rarely get to wash anyone when I'm in the home. I offer my help when I'm finished, or if they want me to go and shower someone, or just get someone ready, or just help finishing off brushing their teeth, doing their hair, little things like that. Because at the end of the day, if you're not helping with that side of care, how are you going to know your patients or residents? Personal care is so important to getting to know the people you're looking after. So I think if you have the time, go and help. in a hospital and in a home, you have a lot of dressings. In the hospital, when someone comes in with a wound, you will refer them to tissue viability. They will come round and do an assessment of the wound and make a care plan for that wound. You will follow the care plan. If anything changes, you will refer back to TVN and they will come and review again. You usually have all the dressings that you need when you're in hospital. In a home, it's a little bit different. Someone might have a skin tear, which you can just put Inodine and, Biotain or a me pour on, just to protect it. But if someone starts to develop a pressure ulcer, or leg ulcer, you have to do a referral to the community tissue viability nurses, and they will do exactly what they do in the hospital and assess and make a plan of what dressings you need to put on. The only difference is in terms of access to dressings is that in a home, the dressings have to be prescribed by the GP. So in order to get the dressings, you have to get the GP to prescribe the dressing, and then it will be delivered and then you can use it. Linking on to the delivery of things, medication gets delivered in the hospital and in a nursing home. In the hospital, when I worked there, it was usually a Wednesday night one of the night shifts, you'd sort out all the medication that was delivered, and you'd have antibiotics, you'd have pain relief, you'd have laxatives, you'd have all kinds of, any kind of medication you can think of, Parkinson's medication, the works. And it would be stocked in a massive stock cupboard. And then when you run out in your drug trolley, you can go and get some from that cupboard and put it in your trolley. In the home, it is not like that at all. You get medication delivered per resident. So whatever they are prescribed, that will be delivered every month. And it will just be enough for a month. If they are prescribed antibiotics in the meantime, maybe they have a chest infection, you will have to take the prescription round to the nearest pharmacy and wait for that and take it back. In terms of paperwork in the hospital, every patient has a big folder with what's going on. Well, they have two folders. They have medical notes, and then they will have their bedside notes. Now, the bedside notes are the things that you'll be filling in every day. The medical notes are things that you should probably keep an eye on to see what's going on, because sometimes doctors or physio or other nurses don't tell you what is going on. They don't come and update you, they just write it in the notes. So it's a good thing to keep an eye on them just to see what's going on. And if you have any concerns about your patient, you can write your concerns in there and also phone the medical team. The bedside notes, however, have to be filled in every day. It's basically a big tick box kind of thing, and you just sign bits, and it's not that it is important paperwork, but that is a lot of what the documentation is. You'll also be filling out food charts, fluid charts, their daily care plans, just filling in what's happened during the day, people have come and seen them and all that. It's just a big lot of documentation of what's happened every day with that patient. In the home, it's a bit different. Everything is done on the computer. It's a big online system, and the carers tend to do all of the notes. They are with the residents more than us nurses are. They tend to be. There are things that us nurses have to do as well. Assessments, and if someone's had a fall, or if someone's been to hospital and they've come back, we have to fill out all that kind of stuff. Also, if there's any alerts that come up, so alerts are things made by the carers to alert us to new changes in the resident, and that could be a new skin condition. Maybe someone's sacrum has got a bit red, or it could be new behaviour symptoms, maybe more confusion, agitation, or maybe they are a bit constipated, haven't had their bowels open in 3 days. So when you get one of them alerts, you will see what you can do, basically. So if someone has a new skin condition, a bit red, go and look at it, see what it looks like, put cream on if it needs, maybe side to side turns. If they're constipated, give them some laxatives and just continue to monitor. Assessments in a hospital are either primary or secondary, depending on whereabouts you work. If you work in A&E or AMU, then you'll be doing a primary assessment. If you work on a ward, you'll be doing a secondary assessment. Now, I worked on a ward, so I was doing secondary assessments, but you still have to ask the patient all the questions that they've probably already been asked downstairs. You ask about their mobility, eating and drinking, if they can keep up together with their hygiene needs, or if they need someone to help them, past medical history, current medication, just a general idea of their health and how they look after themselves. In the home is a bit different. You do a big assessment before they move into the home, so that will usually be in their house or in the hospital, wherever they are currently living, and you will fill out this big assessment, very similar to the one you do in the hospital, except you go into a bit more detail and you ask some more personal questions. You ask things about their home life, where they grew up, what their job was, any hobbies that they have, more of a personal broad picture of the resident, because essentially they're going to live there until they die, really. Some people move out before and they go somewhere else, and some people are there just for respite, but you are there to look after that whole person for the rest of their life, rather than maybe a week or two while they're in hospital. So it's important to get a big understanding of who they're like as a person. Linking on to assessments, when someone comes into hospital, you'll do their height, their weight, work out their BMI, check their OBS and all that. And the weights are usually done weekly and the OBS are done every day. Whereas in the home, you do OBS and weights once a month. So that links in with a monthly assessment that they do, sort of like a monthly review every month. But when it gets to 6 months, you do another big assessment like the one you do before they come in. So in terms of picking up if someone could be poorly or not, you're not checking OBS as regularly as in the hospital. But because they're not acutely unwell, you don't really need to until they start presenting symptoms. In terms of personal things for me that are different, the level of stress is decreased by quite a lot. I still do get stressed about going in and making a mistake or something, but in the hospital, being on permanent nights and constantly in charge of the ward at such a junior point, it really got to me. I was signed off sick for a bit and it wasn't great. Now I still get the stress, but I feel more confident in myself, and I do know what I'm doing, and if I don't, I can ask, and I don't feel so stupid because I'm not the one who's supposed to know everything that's going on. The only thing is you don't have doctors in a nursing home, so you either have to phone 111 or 999 or the GP surgery if it's in hours, which I'm usually not. I usually work weekends, so that's the bit I get a bit nervous about, because in the hospital you can just be like, hi, can you come and have a look at this patient? They seem really different. And then the doctor will come and have a look and do an assessment. I really like the rapport, relationships that you build with the residents as well, compared to in the hospital. Don't get me wrong, I loved working in the hospital and being there to support the patients that are there and getting to know the families and being involved in such a important part of lots of people's lives. But the relationship you build with the residents is they're like family, and I've been there for 5 years, so I've known most of the residents for that long. Or a lot of people that were there when I started are no longer there, so I've seen people through their stay there, and it's nice to be back and enjoying my job and enjoying working with the people that I do and enjoying just seeing the residents. When I first started nursing, nursing home nursing is what I wanted to do. The home I'm in now is where I realise that elderly care is what I want to do. I absolutely love it. And coming back there as a nurse has been so nice, and it feels really rewarding, and a lot of the residents are so happy that I am back and I am their nurse rather than just working in the dining room or the kitchen. I'm sure they wouldn't mind if I still worked in the dining room or the kitchen, but it's nice to have their respect and that they appreciate the work that I do and the rest of the team do. That's all from me. I hope you have enjoyed the video. If you have, make sure to give it a like, and if you want to see more, feel free to subscribe and turn notifications on. I have social media and stuff. I don't really post nursey things, but feel free to follow me. I'll leave the links in the description. Have a nice day, take care, and I will see you in the next video.